Thank you to the moderators, and thank you for the planning committee for the opportunity to present here at SCAI Scientific Sessions 2025. Ladies and gentlemen, on behalf of my national co-PI, Dr. Sahir Sabri, and the investigators of the AVENTUS clinical trial, it is my pleasure to present to you a prospective study of the next generation AVENTUS Thrombectomy System, advancing thrombectomy and autologous blood reinfusion for pulmonary embolism. These are my disclosures. The AVENTUS Thrombectomy System is specifically designed to address some of the current unmet needs within the PE space of thrombectomy devices. The integrated navigation catheter and bevel tip catheter tip obviates the need for multiple wire and dilator exchanges. In addition, an inline filtration system allows us to perform more efficient separation of clot from blood, the latter of which is reinfused back into the patient, minimizing blood loss and shortening procedural time. Lastly, there is a side port that allows us real-time hemodynamic measurement of pulmonary artery pressure, and thus allowing us to understand what are the improvements on the table as we perform procedures on these patients. The AVENTUS pivotal IDE trial was a prospective, multicenter, single-arm study evaluating patients undergoing thrombectomy for acute PE with the AVENTUS Thrombectomy System. Our primary objective was to evaluate the safety and efficacy of the device. Our trial enrolled a total of 120 patients for intention-to-treat analysis across 22 sites. The primary endpoint was a change in the RV to LV ratio on CT-PA from baseline to 48 hours post-procedure, as assessed by core lab imaging analysis. Our safety endpoint was the composite rate of device-related major adverse events, or MAEs, at 48 hours, as adjudicated by an independent clinical events committee. Additional observational endpoints were performed at 48 hours, including a refined modified Miller score change compared to baseline, as well as the length of ICU stay and hospital stay. Lastly, we also evaluated 30-day outcomes, which also included quality of life and functional assessment. Our enrolling sites were geographically distributed throughout the United States with a diversity of operators, totaling 49 unique users. In addition to the 120 intention-to-treat patients, each site was actually permitted to enroll roll-in subjects, up to 2 per site. The reason this was allowed was because this was the first in-human experience with no early feasibility trial and no outside U.S. trial. Despite having the opportunity to enroll up to a total of 50 roll-in patients for the clinical trial, only 10 patients were enrolled as rolled-in patients. Characteristics of our intention-to-treat patients are as noted. The average age was 58.8 years. A large majority of our patients had concomitant DVT, and more than half had pulmonary hypertension based on baseline pulmonary artery pressures. In addition, cardiac biomarkers were elevated in the majority of patients, and 99% of our patients had bilateral pulmonary embolism. We utilized the BOVA score to help us risk stratify our patient population. Compared to the PESI score, BOVA score utilizes non-invasive hemodynamics and signs of right ventricular strain to ascertain the acuity level of the pulmonary embolus, and is independent of patient age as well as comorbidities. BOVA stage 2 and 3 are considered the more advanced stages, with up to 18 and 42% PE-related complications at 30 days, respectively. With that in mind, 87.5% of the intention-to-treat patients within our cohort fell within the advanced stages of BOVA 2 and 3. Using the inline filtration system, the total dwell time of catheter in our procedure was 39.5 minutes, including the filtering and returning of blood. Nearly all of the patients received filtered autologous blood reinfusion, resulting in an estimated blood loss of just 49.6 milliliters. None of the patients received blood transfusion during the procedure. In addition, 60% of the procedures were completed without having the catheter pass through the heart multiple times. So 60% of patients actually underwent the procedure with a single pass of this catheter through the heart. 99% of the patients did not require adjunctive therapy at the time of the procedure. Furthermore, on-table hemodynamic assessment shows significant improvement in both systolic as well as mean PA pressures from pre- and post-thrombectomy. Ladies and gentlemen, I am proud to announce that the AVENTUS clinical trial has met its primary efficacy endpoint of reducing RV to LV ratio from baseline to 48 hours post-procedure, as assessed by CT-PA. The reduction in ratio of 0.47 constitutes a 27% drop compared to the baseline and far exceeds our performance goal of 0.2. Furthermore, no adjunctive therapy was required up to 48 hours post-procedure. The ICU length of stay was also very low, with a mean of 0.8 days, and only 31% of the patients staying more than 24 hours. Similarly, the total hospitalization length of stay was 2.6 days. We observed the greatest reduction in thrombus burden compared to other PE clinical trials, demonstrated by a 35.9% decrease in the refined modified Miller score based on CT-PA, and this was assessed by an independent imaging core laboratory. From a safety perspective, we have also met our primary safety endpoint with no device-related MAEs at 48 hours. Although not formally within the primary safety assessment, we did analyze the non-device-related MAEs up to 48 hours as well, with a very low event rate of 2.5%. No patients received blood transfusion at 48 hours. Lastly, our 30-day safety analysis actually showed no device-related major or serious adverse events. One patient did come back within a week with recurrent PE, primarily due to medication non-response. Finally, this is the first IDE trial in the PE space evaluating quality of life and functional outcomes at 30 days follow-up. Both of these clinical outcomes were significantly improved based on assessment with the pulmonary embolism quality of life questionnaire and 6-minute walk distance. In conclusion, the AVENTUS pivotal trial has met its primary endpoints for both efficacy and safety outcomes, with improvement in RV to LV ratio and no device-related MAEs at 48 hours. Clot burden was efficiently removed, as shown by significant reduction in the refined modified Miller score, and no blood transfusions were utilized at 48 hours. Lastly, we have shown continued improvement in the functional status and quality of life in our patients in the short-term follow-up. On behalf of my esteemed co-investigators, I am honored to report that the AVENTUS Thrombectomy Trial Results have been simultaneously published in JSCAI. Thank you.
That's very, very promising results. Congratulations. I was a little confused on the catheter dwell time was 40 minutes, but when you say it only had a single pass, you're talking about going through the right heart to get to the pulmonary.
That's correct.
So you didn't have to remove it. So all of these bilateral pulmonary emboli, you did change the position. And
that's correct. So it changed positions from left pulmonary, right pulmonary, or upper and lower lobes, but without necessarily having to remove it from the heart.
And how much blood was reinfused into the patient? Was there any way to assess that?
We did actually assess that, and that was primarily based on the number of syringes that were going back, handed back to the person at the front of the table, reinfusing it back into the groin sheath. If I remember correctly, it was over 750 cc's was reinfused back into the patient on average. Yes.
Wow.
That's great. Congratulations.
Thank you.